the job displacement risk is so massive and so fast and across every industry that I think it's impossible. And I mean, there's a lot of people who talk about this in various different, channels, who are experts in the field. I'm no expert, but I think the challenge is that
Welcome to the ReeThink Podcast. Today I have another guest. It's John. He's the co-founder of PIPRA. John, help yourself. Introduce yourself to the audience.
Thanks a lot, Rudi. It's a pleasure to be here. I'm a serial entrepreneur. I'm half French, half American, living in Zurich, and excited to be here and to share a little bit about my background and what I've been.
Great stuff. So I just mentioned PIPRA, that's your current baby. So tell me the story how that happened.
Coffee with a neuroscientist is the short answer.
And the long answer?
Well, I've always been fascinated by brain health and longevity and how we can age healthier. For me, and I think for a lot of science, the brain is still kind of this largely unknown organ, and there's so much potential to learn and to explore, and also to keep our cognition and our brains intact. So it's just something that's super fascinating to me, more like a hobbyist. And about 8 years ago, I was having a coffee with a known neuroscientist in the field of Alzheimer's disease here in Zurich, who was a lecturer at ETH and other things. He was an entrepreneur as well, and he was telling me about this idea he had to start another business. And I loved the idea. I thought it was fantastic, but I also started challenging some of his thoughts and ideas. And kind of as an entrepreneur, when you hear an idea, you immediately start dissecting it and thinking, like, how could it be better or different, or what about this? And it's kind of one of the things that we do. It's just probably annoying for a lot of people, but he loved it, and we got into it, and 3 hours later he said, "Do you want to start a company with me? I love challenges. Let me think about it." It was the beginning of my exploration into the field of neuroscience, and I worked together with him for a couple of years, trying to develop a business focused on prevention of Alzheimer's disease. And that project kind of dovetailed into PIPRA.
Okay, so then can you tell me what was his initial idea and what ultimately led to PIPRA?
Yeah, sure. His idea was he had developed a prediction tool that used augmented reality along with other features to, in a relatively short amount of time, be able to predict if people were at risk of Alzheimer's disease, basically using an iPad. Testing different aspects of cognition, like spatial awareness, executive function, these kinds of things. And memory recall, as you would place objects in a room virtually and then have to refine them, and dual tasking and all these different things. Fascinating technology. And his concern, which was a very valid concern, is it's great for research, pharmacy, whatnot, but what is the point of somebody knowing if they're at risk if there's no cure? There's nothing you can do about it. Yeah. So what he wanted to do was to basically develop a a prevention clinic, basically, where people would get tested, see whether they were at risk, and then have protocols and a team to help navigate these prevention strategies and make sure that they adhere and stick, right? And again, I thought the idea was great, maybe not too scalable, but definitely with some tweaks could be very scalable. And so we sort of got into it. And then we started looking for customers, hoping that we could do something B2B rather than B2C. Because again, if you do B2C, you have this very arduous task of convincing or allowing the general public to be aware of the fact that there is actually a remedy, there is a cure, there is a way to, not a cure, sorry, a way of preventing delirium, right? In order for them to want to actually purchase. So that's a big task, right?
Yeah.
There's a lot of marketing money and a lot of influencing to be able to get enough awareness out there that this is possible. So we were looking for a B2B, and we started talking to insurance companies and hospitals. And what we found quite early on is that it's not really a problem that hospitals face in particular, right? Dementia, Alzheimer's disease, which is a form of dementia, it doesn't really affect hospitals. It's a very slow progressing disease that typically happens at home or in a nursing home. But while I was trying to find a buyer, a stakeholder within the healthcare systems, I started to learn through doctors about this problem called delirium, which I didn't know much about. And it became very evident that delirium was very similar to dementia, much more acute, that it is triggered often during the hospital stay and has severe consequences for the patient as well as for the hospital. So essentially, it's a state of confusion, disorientation, memory loss, hallucinations. It can be extremely terrifying for patients, also very difficult to deal with for healthcare professionals. It's very often described by patients who experience delirium as the most terrifying experience of their life. And many patients don't recover. So, and it ends up costing healthcare systems millions. So that tweaked my interest from a business perspective, because now we had a real problem that we were going to solve, a real need for a customer. And there was a personal angle to it. So as I started to understand a bit more about delirium, I called up my mother and I asked her to tell me again, but with more detail. She doesn't like to talk about herself and her problems. But to tell me a little bit more detail about this experience that she'd had years ago in hospital that sounded very similar. And so she went into it and she described essentially a really terrifying episode of delirium where after a routine surgery, a hip surgery, she woke up and, she thought that the staff in the hospital were trying to kill her. She was hallucinating and saw these terrifying monsters coming out of the walls in her room. And she was there by herself, essentially for days in terror and in pain. And luckily, she made a full recovery. But it definitely left scars because she's terrified of hospitals and doesn't want to go near them. And a lot of patients have this PTSD, this type of scars from this type of surgery. But many have much worse complications. Mortality, so a large percentage of patients with delirium will die within a month. Almost 40% of patients with delirium continue with long-term cognitive complications like dementia. The risk of having dementia goes up 1,400%. The risk of ending up going from the hospital to a nursing home instead of back home goes up 600%. And this is not a rare thing. It's actually very, very common. So one of the goals at PIPRA is to help raise awareness of this problem, because it's a massive, massive disease area that's completely unaddressed, is not discussed enough, and needs to be front and center for anyone considering, going to a hospital. Mm-hmm. Obviously, if it's an emergency case, you have to go. But healthcare systems should be doing anything and everything they can to address this massive problem. It affects nearly 1 in 4 patients over the age of 60 that go to a hospital.
Wow.
That stay overnight. Nearly 1 in 4 patients. Massive.
It is. Can you walk us through what is the trigger? Because what I ask myself is, first of all, there's a distinguishing fact that it's only or mostly older people, and there must be happening something neurologically that this experience will be triggered. So is there research, or is there something that you know, okay, these are the reasons why this delirium happens? Because they are, from my understanding, before the operation, before the surgery, they were fine. And then they have this operation, they have the anesthesia, and later they have a problem that is not directly related to the surgery.
Yeah, so it's a great question. Their delirium is, much like dementia, is very multifaceted. And there are lots of different risk factors, known risk factors. We don't know for a specific patient yet what the specific trigger was. That's something we're working on, and it's an exciting space in research. But what we know is there are certain things that do increase the risk. For example, age. It's a big one. The older you get, the more frail you are, the less cognitive reserve you typically have, and the higher the risk that certain things might trigger and push you into delirium. There are other risk factors like medications, right? Also, especially polymedication. If you're taking lots of different medications, can definitely have an effect. Especially when you are in a hospital and now you combine your daily medication that you're anyways taking with all of the opioids and sedatives and anesthesia, and it's just an immense cocktail of medication that's going through your bloodstream, much of it crossing the blood-brain barrier, creating this storm in your brain of insult, basically, which can tip a person into delirium. There are lots of different risk factors. Some of them are, for example, if it's a surgery, what type of surgery is it? Bigger surgeries tend to come with more risk, mainly because of inflammation. So where there's large surgery, you have a lot of inflammation locally at the site of the surgery, but that will also get into your bloodstream and become systemic and cross the blood-brain barrier and become neuroinflammatory. So there are various different things that can trigger. So when we built a model to predict, we looked at all of the different known risk factors and tried to find which of these factors were most predictive and which ones were mostly routine, that information that would be readily available or easily collectible for every patient, right? Mm-hmm. So for example, MRI data and various omics data, they're very interesting, but these are not things that, at least for now, are routine. They take too much time, they're too costly. You cannot screen every patient before or on admission to a hospital, especially emergency patients. You cannot do an MRI or do, lab and omics data for every patient. It's not possible. So we had to find this nice sweet spot of routine data that also was very predictive.
Okay. Is there a reason why delirium is so under-recognized? Because meeting you, this was the first time I heard something around those lines at all. And for you, it was the same. You, through a different project, you came across this problem. So is there an answer for that, or do you have an own answer for that? Because I'm super curious about that.
Second. I just gonna see if this. There you go. I'm gonna change the light a little bit because I mean I know it's winter, but I'm looking like a snowflake on camera. It's bright, super wet now.
It's probably also the difference between me and you. It's exaggerating the problem.
Sorry about that.
No worries.
Sorry, tell me again what the question was.
Why do you think delirium is under-recognized?
Yeah, that's a great question. Yeah. So it's it's largely under-recognized, mainly because I think clinicians for a long time just kind of assumed delirium is an unfortunate consequence, and happens to some patients who are older and who are frail, and it's kind of, there's nothing you can do about it, and it's, it's just, you just hope that it doesn't happen to too many patients. That's part of it. Of course, now more and more clinicians are understanding that it is actually preventable. Mm-hmm. You can do something about it, and you should, and you absolutely should do something about it, right? So I think that's part of it. I think the other part of it is that there are two flavors of delirium, essentially, or mainly. There's a hyperactive delirium, which is very obvious, where the patient can be extremely agitated, yelling, screaming, very visibly terrified, for example. They might start pulling out their cables and running through the halls, or trying to hurt people or hurt themselves. So it's very obvious. It's actually less common. The more common flavor, let's say, is hypoactive delirium, which is where the patient is completely silent, quiet. They don't say anything. They might be extremely dehydrated, but they don't say anything. They don't drink. They don't talk about the fact that they're massively dehydrated, which just by itself is a big problem. They might be in extreme pain. They don't say anything. They might be hallucinating and terrified and extremely stressed. They don't say anything, right? And so I think a lot of the time these patients get missed. According to literature, 70% of patients with delirium are missed.
Wow.
And it's mainly because of this hypoactive type of delirium.
Yeah.
So now, while it is still something that's not nearly talked about enough, and there needs to be much more awareness on the topic, for sure, mm-hmm. Hospitals are starting to do more about it. Mm-hmm. There are hospitals that are bringing on delirium teams, so people who do have some knowledge and experience with delirium, especially nurses, to try to manage delirium better. They're starting to reach out to PIPRA, for example, to look at ways they can use technology to integrate into their hospital systems and help identify those patients in a very automated and easy way and routine way. Super important because, as I said, it's very difficult to identify when a patient has delirium, but it's also very difficult to predict which patients are going to have delirium.
Yeah.
So, but it's a great question, and we still have a long way to go, but we're moving in the right direction slowly in terms of awareness.
But now it makes sense. Since 70% of the time you are not aware that this is happening, then of course I can see why this is like under-recognized in a sense. So, I mean, you already mentioned a couple of times that you have this predictive, let's say, tool in a sense. So as far as I know, it's the PIPRA risk prediction tool. Can you walk us through how this works and how it's like integrated in the whole like surgical workflow?
Yeah. So if you are, let's say you are having an elective surgery, so you're a knee replacement or hip replacement or something like that, for example, so you schedule surgery. So typically, if you're over a certain age, you will have what's called a pre-anesthesia consult.
Mm-hmm.
So you'll make an appointment, you'll go into the hospital, you'll see typically an anesthesiologist,
Yeah.
and they'll ask you a bunch of questions. Patient history information, like what kind of medications are you taking? Do you have any complications? You know, blah, blah, blah. Some of that information, like age, how old are you, is relevant for our prediction model. So our AI basically sits behind the electronic health record system of a hospital. And as this information is being entered, or may already exist if the patient has a history with the hospital, our our system basically grabs automatically the information that is relevant, like age, BMI, type of surgery, frailty, or ASA scores, these kinds of things. It grabs this information. It then calculates the risk in the cloud in real time based on the training model that we developed. The training model itself was built over several years, collecting and harmonizing a very large database, one of the largest in the world on Delirium, so that we could use that as a baseline to see whether a patient has risk factors or not. And then it calculates the risk. It then stratifies that risk into risk groups from low risk to highest risk.
Yeah.
As well as a percentage of risk. It then writes that back into the electronic health record system so that it's very clear to the clinicians, and then make sure that that's communicated, however it's necessary, to all the different stakeholders in the hospital that need to know. So, for example, nurses in the post-op ward, right? They need to know that this is a high-risk patient and that they need to do certain measures, take certain measures to ensure that this patient doesn't get delirium.
Mm-hmm.
One of those things is also heightened awareness, so that they're more observant of the patient, particularly in the case of hypoactive delirium where they're silent.
Yeah.
Just making sure that there's not some problem there that they would otherwise miss. And yeah, so everything happens automated in the background. And it's very easy to integrate through HL7 FHIR compliant type of solution, which is fairly standardized across most electronic health record systems. But very, very important.
Okay. What I was asking myself, so then therefore the measurements, when you have, like, let's say you have this patient and they are run through your prediction tools. So he's a high risk client in that sense. So the measurement, they are already clear what you do in order to prevent that or be more sensitive about it? Or is it also something that is part of your tooling that it gives, besides of the prediction of the risk, that it gives suggestions for preventing what could end up in a delirium?
Yeah, no, absolutely. So we have a middleware solution which has recommendations for what to do with specific patients, specific risk groups. It also has dashboards and insights that help clinicians to observe and to monitor the patient to make sure that there's a high compliance, adherence to the different things that they need to do. Make sure that they recall what they need to do. So, for example, some of the measures that are very important and will help to prevent delirium is, okay, so now you've identified this patient in this room is a high-risk patient. So far, they're fine. Everything is okay. But they may well become delirious.
Mm-hmm.
Delirium often is visible within, let's say, 1 to 3 days after a surgery, for example. It's not limited to surgery, but let's say within the first day or 2 or 3 of a hospital stay is when delirium will often present.
Yeah.
So at the beginning, it's very important for the nurses in particular, but also geriatrics and internal medicine doctors, to observe the patient, to orient the patient so they know where they are and whether it's day or night, what time it is, these kinds of things, to make sure that they're mobilized early and often, if it's possible, make sure that they're well hydrated, make sure they're sleeping at night and they're awake during the day. Very often in hospitals, patients are woken up at all hours of the night and given medications, and it's very disruptive to their recovery and also very stressful and can also tip them into delirium. So there's various things that actually should be quite standard and routine for all patients.
Yes.
They're not, because simply nurses don't have the time.
Yeah.
They're basically running from problem to problem, right? So if somebody's yelling or they're in pain or whatever, then they get the attention. But somebody with hypoactive delirium who's just staying quiet, even if they're suffering severely, they get ignored. Nobody pays attention to them. So
Yeah.
this is what we're trying to change. But yes, the software that we have is not just a prediction model. It's also dashboards and insights, which are important for adherence to these protocols, but also very relevant for heads of departments and administration to see what is the effect of these tools, right, of using people. How is it reducing, for example, length of stay? Patients with delirium stay much longer.
Yes.
If they don't have delirium, then the average length of stay goes down quite a lot, saves them a lot of money. How is it affecting nursing hours? The patient with delirium often takes much more time of a nurse's time, especially hyperactive delirium. The cost to a hospital is massive. It's on average about 11 million Swiss francs per hospital per year.
Wow.
And that's just based on length of stay.
Yeah.
If you factor in other complications that arise because of delirium, like an increase in falls, infections, pressure ulcers, if you factor in all these other things, the costs go up far more than 11 million. So it's really important from a cost effectiveness perspective, from an operational perspective, to have a very strong prevention strategy in hospital. I mean, obviously for patient outcomes, it's critical, but from a money perspective, which often unfortunately drives decision making, it's critical. And I hadn't mentioned this, but just to give you, and I know I've thrown a lot of numbers out there, but if it's interesting, I can tell you just how big a problem this is globally.
Sure, go ahead.
Kind of staggering. Delirium is 60% more expensive to healthcare than diabetes.
Oh my God, yeah. And is it big? Sorry? No, go ahead.
No, I was just going to say that number comes from the United States.
Wow.
Where diabetes is not a small issue.
Yeah, it's rampant. Oh my God.
It affects over 60 million people a year.
Wow.
So this literally is one of the biggest problems in healthcare.
Yeah. And it's interesting. Before you mentioned that, I was already thinking, okay, with your solution, this will save a lot of costs. Like the thing that you have created with your team basically is like the textbook, let's say, entrepreneurial case. You had identified a problem that leads to a lot of savings if this is fixed, and there was not a like proper solution that addressed that, and it was kind of hidden. So from the normal perspective, it must be a breeze in order to get this on the market and to get the clinics and the hospitals to adopt it. But what was the reality of that process? And maybe you can walk us through what the challenges was and whether it was a breeze or not, and why.
Yeah, no, it was a piece of cake. Yeah, so a lot of challenges. First challenge is working in medical device technology is you need to source the data. You need to collect a large amount of data to have a large population size, to effect size, to make sure that it's accurate and relevant. And that can take a long time through clinical studies, partnering. Then once you have the data, then it's harmonized and collated and aggregated into a working database that you can use to train your model. Then you do your validation studies to see whether it actually works. Is it predictive? That takes a long time. Then you get the results back and then you certify as a medical device through the regulatory process. That takes a lot of time. Mm-hmm. Now you're certified as a medical device and you think, woohoo, now I can go sell this, right? Mm-hmm. It's certified. It's based on large population size data. It's been published in peer-reviewed high impact journals, that it works. Everybody's going to want this. It's addressing a big problem. Clear. Now we need to validate that the medical device works, right? Now it's certified as a medical device. So now we have to do validation studies in specific geographies where your customers are based, because just because you show that it works in Germany doesn't mean that people in Switzerland are going to accept it. So you have to do validation studies. And then you think, okay, now it's been validated in several countries. Yeah. Always with a great result. Now people are going to finally buy this, right? Mm-hmm. Now they want to see cost effectiveness studies. Okay, it works, but how much is it going to save us? Yeah. Now you have to do cost effectiveness. It takes a long time. It costs a lot of money. Then you get the cost effectiveness results, and it's staggering. It shows, in our case, that using PIPRA can save a mid-sized hospital 2.5 million Swiss francs per 1,000 patients screened. So that's easily 10 million Swiss francs in cost savings over a medium-sized hospital. Now you think, okay, we finally have everything we need. Yeah. Now it should be easy, right? It's still not easy. And part of it is because it's a new category. It's not that we are replacing a scalpel with a slightly better scalpel, or whatever. It's not that they go, oh, we use this every day, so we see that this is slightly better or cheaper or whatever, so we're just going to use yours instead. No. Now what we're doing is we're adding something that doesn't exist into a workflow. And hospitals are incredibly slow at changing and extremely resistant to change, even if they recognize something there's a problem. So it's a big challenge to not just identify a problem, bring all the evidence, but then also be able to convince the team and the administration that this will work in their hospital and that it will be adopted by all the various different stakeholders that need to be involved. So it's a big challenge. I mean, we have had a lot of fantastic things happen at PIPRA, but it's been definitely pushing a rock up a hill for a long time. We're finally starting to see the light at the end of the tunnel, and we're starting to see interest coming from major hospitals in the United States, in Spain, in Germany, in Switzerland, and so it's an exciting time for us. We're really kind of on the precipice of this finally taking off. But, if we can keep our company funded and we can survive long enough till all these contracts come in, then we're going to be in great shape.
Sounds good. But at the same token, it almost sounds like every entrepreneurial endeavor. That is, it's such a struggle and hard time, although the evidence is there is a problem that needs to be solved. But the resistance from the markets, from all these different factors, stakeholders, investors, you name it, are so big that they're, and I can get it that at some point you think, why should I continue doing that? But you've been so far you are hooked on this because you built already a couple of enterprises or startups. Yeah, tell me, what was the biggest learning so far besides of what you just mentioned with PIPRA?
The biggest learning on my entrepreneurial journey?
Mm-hmm.
So many. I don't know what the biggest one is. Definitely one of the biggest learnings has been, and I know it's very obvious, and it's, maybe nothing. Investing time and energy into finding brilliant team that work well together, that have the right culture, that from the very beginning, from the interview process, you feel that they're going to be a good fit in the culture that you've created,
Mm-hmm.
or that they are going to, if it's the very beginning, that they're going to have the right kind of personality that fits with the culture that you want. Having an incredible CV is not enough.
Mm-hmm.
I'd rather take somebody who doesn't have the perfect CV, but has the grit and the determination and the passion and the right culture, the right vibe. I'd rather take them over somebody who has a better CV any day of the week. So finding the right team and then investing not just the time in finding the right team and building that culture, but then keeping that culture and spending the time with them as often as you can, with one-on-ones and doing team events and making sure that you're creating a place that you love to go to work
Yes.
in and that people love to work in. Because at the end of the day, with a startup, there's so many ups and downs. There's so much uncertainty. There will come times where you need your team to pull together, and they'll only do that if they love what they're doing and they're passionate about it. Team, that's what keeps them. It's not the money. So I think that's one of the biggest learnings. Yeah, I think it's really important as a management or as a CEO to hire people who are just brilliant and much smarter than you, particularly in their field, and just get out of their way and let them do what they do.
Yeah.
If somebody's motivated and brilliant, you don't really need to tell them what to do.
Makes sense.
They'll just do it. And if anything, telling them what to do might just be the wrong thing. It might be getting in their way.
Mm-hmm.
Because, they're passionate. They know what they're doing. They know their topic. Obviously we talk, we challenge each other, but it shouldn't come from pushing. It shouldn't come from, you have a deadline. I think it should come from, like, do you want this to work? Can you make this work? Are you passionate about making this work? Because then you get gold. Yeah.
Do you have a story that you can tell that encapsulate one of your learnings?
I have a story that is, like one of my other companies, I hired a COO consultant who had an amazing CV and, brilliant background, and he spoke so smoothly and, and just had so much managerial experience. And I thought, this is going to be great for operations. He's going to be something I had a gut feeling that something wasn't right. Culturally, I just had something but everything looks so good. And I hired him. And that was a big mistake. Big mistake, because he ended up being somebody who was very destructive, very self-centered. Yeah, did a lot of damage. So I think you have to be. That's why I think from there, that was one of the learnings. Like, take the time. I think it's really important also in the interview process to, and I think most companies do this anyways, but to not just leave it for HR or just to do it yourself, you know, if you're very small, but to get as many of the team members as possible that you value, especially from management, to do one-on-ones with them as well, to do interviews by themselves. And then you compare and you all talk, because you might miss something that somebody else saw clearly.
Yeah.
And especially if a couple of you are saying, well, I'm not sure about this thing, even if it's like a big need because you haven't, you've got customers calling, you need to get this stuff delivered, you need to hire for this position, you know, it's like, it's so urgent. Don't hire that person. If it's not the right fit, just wait.
Yeah. That's also something, I'm not sure where I heard it, but at some point I heard it from it was also a startup, and also the founder told me, like, the way we have our hiring process is that we make sure that the candidate speaks to a lot of people from our team to get as many perspectives as possible. And if we have that, and we have like a, let's say, general understanding of that person, that this person might be a fit, then we go for it. And the other thing that I always hear is like, it's rather important that you have the right person on the bus. It's not so important what their role will be. It's just from the perspective of the person with their character and their values that it's more important than the skills, because the skills can be something that can be learned.
And absolutely. And speaking about values, one of my other learnings, just how important it is to be very clear about what the values of your company are, and then to make that very clear to everybody on the team often. So for example, whenever we hire somebody new, we have a onboarding where we kind of all get together and we welcome the person together, and we talk about the most important thing, which is, why are we doing this? Why are we getting up in the morning every day and struggling and pushing and pushing? You know, in the case of PIPRA, it's to create a world without delirium. It's to improve and save lives, right? That's our why. And to make sure that that's super clear. And then the values that we have in the company, you know, we literally put them up on the wall in the office, so that it's a constant reminder of what we want, to the energy that we want in the office. But it's also not just about internal, it's also how we reflect externally, right?
Yeah.
Because if we have these strong values and we live by them internally, that's going to extend outwards as well, as we go to different events, talk on stage, as we communicate with our customers. Those values are going to be present well. They're going to radiate through us as well. So I think that's really, really important in creating a really good culture.
It's so interesting that on the one hand, like, for instance, I mean, diverse opinions is something that is like very sought after, but at the same time, you want also cohesion in a sense, in particular in a startup. And it almost feels like that is a conundrum in that sense, that it's not working together, but it's super important, because whenever I see a company that is like crushing it, they have a really cohesive culture. So they are like similar type of people in that sense, that, for instance, they all like Star Trek, or they all like Star Wars, or whatever it is. And it helps, in particular in the beginning, to be very cohesive in that sense.
Yeah, that's an interesting reflection. I think balance is what you want to strive for there. In my opinion, in my perspective, it's like, I think if you have a team where there's enough similarities, interests, values. There's enough because everybody brings their own value. You can have the company values and push that as much as you can, but people also have their own value system, right? So if you have cohesiveness there, I think that's really important. But I think also having diversity and having difference is super important, because first of all, the product that you're selling is for a diverse population, typically, right? In almost all cases. So you need to understand, a lot of the time but there are examples of terrible marketing because they didn't think about a certain, population, right? Ethnicity or whatever. And people were super offended, right? So it's really important to have, I think, diversity on the team, because you're selling to the world that's diverse. And you want to have those challenges, and you want to have those different perspectives. So I think if you have too much diversity and too much difference, and people don't see eye to eye, then I think it's difficult. So I think it's a nice balance of striving for of cohesiveness, but also of difference.
Yeah, that's great. And what I also love to hear from your perspective is, you have integrated AI in a tool that is used by clinics and hospitals. What is your general view on AI?
So that's not a small question today.
You like challenges, right?
Depends how honest you want me to be. My general view is that AI has incredible potential to do good. How we've learned to understand through AI misfolded proteins and the implications of understanding proteins better and how they should fold is a game changer. It's massive. Like we are using AI right now to cure and solve previously unsolvable diseases and issues. Incredible. It has the ability to make us so much more productive, which is amazing. And typically when you have an increase in productivity, you also have increased economy. I think there's great uses of it in mental health as well, although limitations still. There's great uses of AI in so many different fields, especially in like AI and robotics, where people were or are doing very dangerous jobs. This can be done by machines. Fantastic. Problem with AI is, in the past, when we've had new technologies that have been introduced, the internet, there was always a fear around, is this going to take away? And in many cases it did. But the evolution happened slowly. The transition to adoption happened slowly. And during that phase, people could learn new skills and there were new jobs created, which they could then do, right? So you ended up without any issues, right? If anything, was an increase in economy and GDP. With AI, the job displacement risk is so massive and so fast, and across every industry, that I think it's impossible. And there's a lot of people who talk about this in various different, channels, who are experts in the field. I'm no expert, but I think the challenge is that we just can't possibly learn enough and quickly enough. Whatever new jobs are created. To displace the job loss, which is happening now and will increase massively. There's a lot of predictions that 95% of jobs will go away. We cannot learn, and fast. We cannot learn enough to take on whatever new jobs are created. And those new jobs that are created, AI will figure out, and robotics will figure out how to do those jobs themselves better and faster than we will.
Yeah.
So the future is very scary. Universal income is a nice concept if it works, but the amount of times that wealthy, incredibly rich people decided to give their money away. I don't know how often that's happened, but not very often, particularly not outside of their own country. So the United States perhaps creates tremendous wealth at the very top.
Yeah.
Who, these AI companies, are they going to then distribute that wealth not just throughout the United States, but globally? It's not going to happen. So on the one hand, I'm very excited, especially in health. I think what I'm doing, what we're doing at PIPRA, my incredible team, it's very exciting, and we're saving lives, we're improving lives. But as AI continues to grow and to take on more and more jobs, take over more and more jobs, I mean, just transportation alone, I think there's 2 billion people that are in some form or other in the transport world, driving trucks, cars, taxis, planes. What are you going to do with 2 billion people who are just out of work?
The thing is, I feel like exactly as you described, I think we are having, on the one hand, through AI, enormous potential. On the other hand, enormous complexity, and this is wrapped around something that is moving way faster than we ever had in recent time. And I think what is almost lost is that we as a collective shaping where it goes. At this point of time, I'm very optimistic in that sense. I don't believe that it will replace every job at a certain point of time, because for me, the way I think is, when we at the stage that we have like a super general intelligence, then there's no point of either of us working. And then I think then the problem is way different. In the long run, of course, what I can see is the extension of things. In that sense, for instance, you used to need, let's say Salesforce. It's a company, maybe they have 100,000 employees. Going forward, you can do something similar to Salesforce with maybe 500 people. This is what I currently see coming probably in the next 5 to 10 years to be very common. However, beyond that, it's really hard. And the other thing is, as you also said, is the dynamic. And the dynamic accelerates. That's the thing. Because 5 years ago, we had this, like, all the major breakthroughs in AI with deep learning and all this stuff. But now we have, like, for 2 or 3 years now, ChatGPT, which was a major breakthrough. It's like the amount of breakthroughs are coming faster, and that's something that is really hard to comprehend in that sense. So that's also a factor, and so that's why I'm a bit optimistic on the one hand, but I'm also pessimistic when we don't take full ownership and also understand like the second, third, and fourth order consequences of what might happen, because most of the time the innovation is driven by companies which they have only their own incentives in line, like their stakeholders, also the shareholders, and potentially with potentially their clients. But beyond that, it's something that is not on the map, and I can see it with social media. It's like, for instance, X. X has influence of all of our lives, although I'm not a user. You might not be a user as well, but it has. So on the one hand, I think in order to take really responsibilities, you might argue these companies need to share the wealth creation from that. On the other hand, it's like, that's not the system that we have currently. So it's really like, that's the thing. We are coming with things that needs totally new perspective, and that were not done in the past, and it's in a pace that we are not used to at all. So that is super curious, and I think it's exciting, but it's also scary, as you said.
Exactly. Yeah. Luckily, I'm working in a field with my team where we get to see a massive, enormous benefit from using AI to do good.
Yeah.
And
Yeah.
we're not alone. There's so many companies that are doing incredible good in the space of health, and I think it's one of the most exciting areas for AI deployment and innovation. And we're just at the beginning.
Yeah.
We
As-
are going to be solving unsolved problems and diseases at scale, and
yeah.
it's super exciting.
Indeed, it is.
To live
What?
in a world where people don't have to worry about blindness or being paraplegic or things it's all these things that hopefully are coming soon.
Mhm.
Extremely exciting. So,
Indeed.
but yeah, governments need to be doing something about this and fast, because the distribution of wealth is a real concern, really, really big concern. These massive companies are going to become more and more profitable because they're laying off more and more people and using more and more technology to run their companies so they can be much more profitable. But that profit stays in the company and with the shareholders. It doesn't get distributed. You would have to tax them to such a massive degree to be able to distribute that, and actually the opposite happens. They get tax
Yeah.
breaks. So
Yeah. Sounds exciting. Let's see how it pans out. And my last question for you: what is your long-term vision for the 5 to 10 years with PIPRA?
So we want to create a world without delirium. That's our current focus. But long term, we want to be solving for all different types of complications that arise in hospital.
Mm-hmm.
So that when you go to the hospital, you leave better than you arrived, not worse.
Mm-hmm. Yeah.
And unfortunately, still today, many, many patients are worse off after the hospital visit than before. We want to change that.
That's great. Thank you, John, for being on the pod. And it was a pleasure talking to you. And hopefully we see each other soon in Zurich.
I hope so. Thank you so much, Rudi. It's been a pleasure.
Bye.
Take care.